In this case, we have a 32-year-old male presenting with exertional breathlessness. The patient has a normal white cell and platelet count, but is markedly anemic. Let's see what the blood film shows. At low power, it is clear that the patient is anemic with a marked reduction in red cells. One thing that is prominent is the absence of significant polychromasia. There are some reticulocytes, but overall this is disproportionately low for the anemia seen. The red cells show a significant variation in size and shape, otherwise known as anesiopoikilocytosis. It's important to assess the red cell size. Along with the mean cell volume, this can be done by comparing the red cells to a reference cell. The normal red cell should be approximately the same size of the nucleus of a small mature lymphocyte, like this example shown by the red arrow. The blue arrow shows this red cell to be bigger than the lymphocyte nucleus. The red cell is also oval in shape and therefore described as an oval macrocyte. There are also other red cell shapes and sizes, like this microspherocyte, teardrop poikilocyte, and red cell fragment or schistocyte. There are also some nucleated red cells. Although they are not prominent in number, they can be seen. These show abnormal morphology, like these examples shown here, with nuclear indentation as shown by this cell here. What about the white cells? Well, we can see normal neutrophils, like the cell highlighted by the red arrow. Some neutrophils, however, show an increased number of nuclear lobes. Here, the cell highlighted by the blue arrow has 6 lobes. Normally, neutrophils have between 2 to 5 nuclear lobes. This finding is also known as right shift, reflecting hypermaturity. The cell next to the blue arrow also shows more than 5 nuclear lobes. The platelet count and morphology are both normal. We also saw no blasts in this blood film. So what should we do next? The first thing that should be considered is a diagnosis of megaloblastic anemia. This is because of the classical features that we've seen, namely reduced reticulocyte numbers, red cell anesiopoikilocytosis, and hypersegmented neutrophils. This is most commonly due to vitamin B12 or folate deficiency. Vitamin B12 and folate levels will help establish this, although this can be inaccurate in certain patient groups, like pregnant women. A reticulocyte count will also allow correlation with the reduced polychromasia. Folate deficiency is unlikely in most areas of the world, due to folate supplementation in many parts of the food supply. So why is polychromasia absent? Well, in megaloblastic anemia, there's inhibition of DNA synthesis. This leads to a maturation arrest at the early erythroid stage. The bone marrow hence will often show high numbers of early erythroid precursors, like pronormoblasts, indicating left shift. Sometimes these early erythroid precursors can spill into the blood and be seen in the blood film. An absence of polychromasia is often seen in patients with severe hemorrhage. This is unlikely in this case because the patient is so anemic. Such a low hemoglobin concentration points towards a chronic process, allowing the body to compensate. A patient with severe hemorrhage will unlikely tolerate such a low hemoglobin concentration if it develops over a short period. Due to abnormal DNA synthesis, red cells that are able to mature are often abnormal, producing the wide variation in red cell size and shape. This is often referred to as dysplasia. So what are the typical findings seen in megaloblastic anemia? With regards to the red cells, there's variable anemia, and in some patients the hemoglobin may be normal. In severe disease, the red cells are increased in size, often with a mean cell volume in excess of 120 femtoliters in severe disease. Oval macrocytes are relatively specific for megaloblastic anemia. As mentioned previously, red cell anesiopoikilocytosis and a low reticulocyte count is typically seen. What about the neutrophils and platelets? Well, both mild leukopenia and thrombocytopenia can be seen. Right shift with hypersegmented neutrophils are typically observed. This feature may, however, be infrequently seen in the blood film. A formula which calculates the segmentation index can help. A value of more than 1.69 is abnormal and confirms hypersegmentation. Rarely, macropolycytes can be seen. These are very large hypersegmented neutrophils, like this example shown here. What other diagnoses should be considered? And if considering a diagnosis of megaloblastic anemia, what other clinical features should be considered? Well, vitamin B12 and folate deficiencies are often due to inadequate dietary intake. Rarely, autoantibodies directed against intrinsic factor can form. Intrinsic factor is a key component in the absorption of vitamin B12 in the small intestine. This is known as pernicious anemia. Along with vitamin B12 or folate deficiency, certain medications like methotrexate and hydroxycarbamide can also induce megaloblastic anemia. Myelodysplastic syndrome, or MDS, can also present with these features. It's therefore important to correlate the patient's clinical history and results of other investigations before making this diagnosis. The presence of blast cells would be more in keeping with MDS rather than megaloblastic anemia. The final diagnosis in this patient was indeed severe vitamin B12 deficiency. The patient had a very low vitamin B12 level, but had a normal blood count only 3 weeks after starting intensive replacement therapy. His low vitamin B12 levels were due to a diet absent of foods rich in this essential vitamin, namely meat, fish, poultry, eggs, and dairy products.